afternoon, everybody. I am going to present my case, recognition and management of systemic vasculitis with CRVO as a warning call. I am presenting a case of 61-year-old male who complained of right eye diminution of vision for 2 weeks. He is known case of hypertension, interstitial lung disease, benign prostatic hyperplasia, and P-ANCA positive vasculitis. He is already treated with pulmonary TB, COVID pneumonia, and he was positive for HBV and HBC. He was already medicated with IV cyclophosphamide, IV MP, tabceptran, tenofovir, and was on maintenance dose of 12.5 mg prednisolone. His vision on first visit was 6/12 part and IOP was 11 mm of Hg. On examination, his lens showed immature senile cataract with nuclear sclerosis grade 2. Disc was mild pallor. Foveal reflex was dull, which was confirmed on OCT as cystoid macular edema with fundus showing dilated veins and mid-periphery dot plot hemorrhages. His left eye showed immature senile cataract of grade 2. Now we made the differential of ocular ischemic syndrome with cystoid macular edema or CRVO with cystoid macular edema. So we did the thorough workup with BP wing 1110 by 60 mm of Hg, CT angio and MRI neck was normal, but MRI brain showed chronic microvascular ischemic changes. So we planned him for first intravitreal injection. Now 1 week post-op his vision was 6/9, but on one post-op he came with complaints of diminution of vision for 2 weeks and his vision was 5/60. We noted the cotton wool spots and the ischemic component, that is hyperreflectivity and thickening of inner retinal layers. Now we made the probable diagnosis of secondary vascular occlusion post-vasculitis, that is ocular flare-up. Now we advised hypercoagulative profile and complete uveitic profile. He was under the care of nephrologist, so we planned him for FFA clearance and stepping up the steroids with planning of for IVMP, 1 gram slow IV infusion, 3 doses. Now FFA showed staining of vessels and dull foveal reflex. 2 week post IVMP, his vision was 6/24, his cotton wool spots were resolving and he was switched to mycophenolate myofertil. 2 months post IVMP, he again came with edema, so we planned him for second dose of intravitreal injection aflibercept. Now, 1 month and second month post-op, his vision was improving. In between, the patient consulted higher center and he was advised to continue same treatment and look for neovascularization. 3 months post-injection, the patient came with vision of 6/24 and his foveal reflex was dull with cystoid macular edema and he was on oral dose of 10 mg of steroids. So we planned him for intravitreal injection Ozurdex. Now, on his last follow-up, that is of 10th of March, his edema is reduced, is presently on 7.5 mg oral steroids and is under the care of nephrologist. Now, for his systemic evaluation. Now, the take-home message here is we need to keep a keen eye to look for the signs of vasculitis. Also, the collaborative effort between rheumatologist and ophthalmologist is very necessary. Also, it is not a one-point treatment approach. So, we need to long-term follow up the patient like he follows up with rheumatologist. Thank you.
What was the systemic disease? Why was the patient be given hepatitis B treatment?
Sir, he was HPV, remote HPV and C positive.
So if it's positive, then why are you giving so much immunosuppression?
So because his edema was reoccurring.
So the treatment for vasculitis is a local steroid or a systemic immunosuppression? You already the patient is on cyclophosphamide. So why did you shift him to rituximab?
So we didn't shift to rituximab because he was having HPC positive. Rituximab causes liver, couldn't be given in liver failure patients. So he was planned, but because of the liver condition, he was not given.
So why do you need to give steroid if you think the patient is hepatitis B and C positive? Then just give local Ozurdex. Why do you want to give systemic treatment for one eye? Either the patient has systemic vasculitis, the eye becomes a window to the brain. If the brain has active vasculitis, then it is life-threatening. But if it's a local one-eye pathology, the local steroid would work. Why would you want to give oral steroids in a hepatitis B and C positive patient?
So like we consulted the nephrologist.
No, I'm just thinking aloud. You should, as an ophthalmologist, don't think only of the eye, think of the systemic. So if you have a patient who has systemic pathology, then higher immunosuppression is required long-term. Short-term steroid is never going to be treated in a vasculitis because the vasculitis will last 5 to 10 years. If it's a local pathology, one eye involved, then the local steroid would do in an active infection. Just think about it.
Just add on to what Amit is saying, ki you gave anti-VEGF as the first line of treatment in this patient.
Yes, so because earlier we were...
So the first line should be Ozurdex, local steroid as compared to anti-VEGF in cases of vasculitis. So our take home is ki steroid, local steroid first, then go ahead with the systemic immunosuppression.
If you have systemic inflammation, then you give systemic steroids. If that is contraindicated, give local steroids. Anti-VEGF will not reduce the local inflammation. In an inflammatory disorder, steroid will work better than anti-VEGF.
And actually,
Yeah, so
posterior subtenon steroid also works very nice in these kind of cases. So it's not necessary that you give intravitreal Ozurdex. You can also give a PST tricot, and many cases will respond. If it doesn't respond, then you can go ahead and give an intravitreal steroids.
See, macular edema is never an emergency. You can treat macular edema with a diabetic and all. You can wait for a month and control the systemic features. So even if you go by the focus trial in uveitis, macular edema is never an emergency.
So like earlier he didn't had cotton wool spots. So we were suspecting ocular ischemic syndrome because he had mid-peripheral
No, ocular ischemic syndrome will only occur in vasculitis. The disease is systemic. It's not a localized disease. Okay, so localized disease can be treated locally. Systemic has to be treated systemically. So if you're giving short-term steroid for systemic vasculitis, with no systemic inflammatory, with active infection, it's better to treat locally. Okay,
Thank you so much.